So first of all, thanks for the kind introduction. Is regarding ultrasound, and whenever any patient is coming to you, definitely they will be coming with a thyroid nodule or instantly declared nodule from outside. So definitely we'll be going through the clinical examination, thyroid function test, ultrasonography, and final aspiration cytology. If you go through the history, earlier people used to auscultate patient. That's what I shown in the figure. You can have a close proximity and hear the heart sounds. Latest telescope came. Same way, nowadays the palpation is being changing over to electronic palpation, so called ultrasonography.
Tharmal, can you just improve your voice a little bit?
Yes, sir. Yes, sir.
Increase your voice a little.
Okay, sir. Can you hear me clearly, sir? Is it okay now?
Yeah, it's better. It's better now.
Okay. So first of all, we should know what is an ultrasonography. So ultrasonography is a medical imaging technique that is using high frequency sound wave and their echoes. The technique is in similar with the one's echo localization in submarines. So basically piezoelectric elements are there. So that will be producing this electrical pulse. So the electrical energy will be converted to ultrasound waves, and it will be passed through the tissue, and you will have a reflected tissues. So whenever you are putting an ultrasound property, it will have a piezoelectric material. So that will be producing the ultrasonic waves, and that will be receiving back the waves reflected from the tissue, and that will be converted back to electrical energy. That is a principle of an ultrasound. A probe will be having one piezoelectric element. That is the most important part of a ultrasonogram. And basically, first thing you should know is there is two characteristics. One is frequency of ultrasound versus resolution. Frequency is one of the most important factor in ultrasound, because if the frequency is high, because we are already talking about high resolution ultrasonography and all. So if the frequency is higher, the resolution is better. So, but the only thing is, like, if the frequency is higher, the depth of penetration will be lesser. So superficial structures only you can see it clearly. So that is why it's really important for thyroid, because it is a superficial structure. It is not too deep. So we should use a high resolution, and the same way depth of penetration as well. So whenever you are, as I mentioned, the piezoelectric material will be producing ultrasonic waves that will be transmitted to the tissues. So, and depending on the tissue impedance, that will be reflected back. Okay, so there will be a difference in, depending on the density of tissue, there will be difference in frequency of the ultrasonic waves, and that will be electronically presented as dots. So the brightness of the dots is proportional to the strength of the returning echo. So the location of the dots is determined by the travel time and the velocity of tissue as well. So by using this, we will get this electronic signal will be converted into a grayscale image. So the most important part is this acoustic impedance. So whenever this ultrasonic sonic wave will be transmitted into the tissue, there will be a change in resistance pattern between the tissue. At the margin, you will get the maximum change in this frequency. So important feature is reflection. And there is another phenomenon called rarefaction. This is the cause for we are getting artifacts. And there is transmission. That means when it is passing through the tissue, whenever it goes deeper, it will get attenuated and reflected back also, and it will slowly weaken. Come to the history of ultrasonography. Howdy in 1955 basically reported using ultrasonography, and it was introduced to famous Fujimoto. I think so many like company from Japan is also quoting Fujimoto as a person behind ultrasound. So what is the use of ultrasonography in a thyroid imaging? Basically, first is as a simple screening tool that can be used in in field trials, other than in OPD as well, and those can be used to whoever coming to you detected to have a nodule as such, you can use to characterize the thyroid nodule. Second thing is, before surgery, ultrasound is a tool to plan treatment. Plan treatment means you can look at the thyroid nodule, you can have an anatomical plan, you can look at the lymph nodes, And the same way, you can have a plan about infiltration, all those things. And the last thing is follow up. So the follow up, having one more important tool, as Sabasar already mentioned, in post-op, in immediate post-op, patient is having some breathing difficulty, and also we will always get scared, like, oh, is there any injury? Actually, I had one patient having a normal voice arrest. I was really panicking at the time. At that time, so normally, what we should do, we should call the ENT person and do an indirect laryngoscopy. In that case, it was very difficult. So I got a OT ultrasound as well. We just had a look at the both vocal cords there. So normally both were moving perfect. So actually the patient was obstructed sleep apnea. That was the question I asked to Pooja madam. In OSA patient, post intubation injuries and all, there may be some edema that can mimic a stridor. So that can you can distinguish. Second thing, in follow-up patient, you can look at the even seroma. You can have a assessment, and in after post-op, every visit we can have an ultrasound to look at any recurrences, lymph nodes are there. So whenever you are talking about ultrasound, we should know the ultrasound, how to use it properly. So we'll be already knowing there's something called as a gray scale. That is a very basic scale. Then tissue harmonics, that is one new that come up. Then adaptive coloring, because adaptive coloring and tissue harmonics is very, very important in an isoechoic and hyperechoic nodules, because a margin assessment is very important in a thyroid nodule assessment. If you're using a tissue harmonics or adaptive coloring, in isoechoic node, we can very well make out the margins are clearly. Another thing is the color Doppler imaging, power Doppler imaging. There is also small differences too. I will come across it later. And grayscale KD, vascular 3D imaging, and panoramic scan. So regarding the grayscale imaging, is a very well-known thing. It's a basic thing. You can characterize the nodule using grayscale imaging. It's almost having 256 shades of gray. But the problem with the grayscale imaging is in isoechoic nodules and in hyperechoic nodules, there may be a difficulty in assessing the margins and lobulations in a Graves' disease and Hashimoto thyroiditis also. You may feel like having a pseudo lobulation that cannot be distinguished properly in a grayscale ultrasound. But if you are using color grading or harmonic imaging, you can very well make out with that. Then there comes a harmonic. Harmonic is an algorithm basically. Normally in harmonics, what happens is like high frequency, signals will travel high pressure signals will travel faster compared to low pressure signals. So this will create a characteristic difference. So this is very, very important, especially in the interface level, because we at the interface layer there is a high probability to have a tissue distortion and signal distortion that will cause artifact that can be avoided in this harmonic echo. So it is very good tool to definitely look at the edges and the margins. So we can especially as I mentioned earlier, pseudolobulations and nodules you can very well make out, especially in a thyroid nodule with thyroiditis surroundings. So the second thing is the adaptive coloring. Adaptive coloring is the color map as such. It is you actually, if you're using a gray scale, only you having 256 shades of gray only. But in grayscale imaging, the margins can be well made out compared to the other things. So it is perfectly, it should be used in an isoechoic thyroid nodule, because what happens in most of the time is like once a thyroiditis patient comes, you will find a ultrasound report telling that there is no nodule. You will find another ultrasound report telling that there is a nodule of 2 in 1 centimeter or something. So the patient will be also confused, sir, what happened? It is resolved or something like that. So only thing is like basically you have to use the harmonic, you have to use the adaptive coloring, look at it, and basically you can very well make out there's a pseudolobulation or a nodule is there. There comes the color Doppler imaging. With color Doppler imaging, we will be having, we can visualize the vascular structures, especially, and here the things can be assessed as a vascular pattern, symmetry of vascularity, regularity of vascular structure within the thyroid parenchyma. Basically, there's not so much importance in be given for this color Doppler imaging in terms of Tourette imaging and all, because significantly malignancy benign recognition it doesn't have much of a role. But the main role in color Doppler imaging in thyroid imaging, one existing in the Graves diagnosis. Graves is having you can have a typical pattern of inferno pattern in Graves imaging. The second thing is in parathyroid imaging. Definitely, the parathyroid vascularity pattern is distinctly different than a thyroid vascularity pattern that you can assess using a color Doppler imaging. Next is the color pixel density. It is actually to trying to quantify the vascularity using the color pixel density. Actually, this is the earlier it is used commonly. Nowadays, it's not common. It is a ratio of area covered by color. It's more of manual. If it is exceed 15% of the vascularity, you can consider it as it is increased more in a hyperthyroid cases. And current cartograms also having a similar possibility plan. You will be the color spots will be compared with the normal areas. If you find more than 10 vessels, there is definitely an increase in vascularity. And so whenever you are doing an ultrasonography, you can always look at it's a perinodular vascularity, mixed vascularity, or central vascularity, or a avascular nodule as such. And most important part of this color imaging is nowadays is like whenever you are going for a fine needle aspiration cytology or you are going for a thyroid ablation techniques, better to avoid the larger vessels. That's the most important thing. And whenever you're performing a fine needle aspiration, definitely avoid larger vessel because that are going to stain and ruin your slides as well, and it can cause hematoma as well. That's the most important part. And coming to the power Doppler imaging, power Doppler basically it's a technique basically that it will avoid the angle between the beam and the blood flow. So the best part is like aliasing artifact will be avoided, and it is more sensitive compared to the color Doppler imaging. So the visibility in a better way. And in pulse wave Doppler, this is having more impact nowadays because this is having they will have a Doppler shift and there will be a waveform in this power Doppler imaging. So you can calculate the average peak systolic velocity, end diastolic velocity, and resistive index. This is having significance in Graves' disease and hyperthyroid cases, even though it is not diagnostic. Now, recent studies are coming up regarding this, especially people who are presenting with a hyperthyroidism and started on antithyroid drugs. You can follow up with the average peak systolic velocity later. And papers are coming up with that only. So there are no, I think 2-3 papers I came across with that. If there is a gradation, actually you can taper the drug based on the change in the average peak systolic velocity after ATT. And the remissions and relapses can be more balanced if you're using the pulse wave Doppler in that pattern. And the resistive index is the developed by Leander Perret, is a measure of pulsatile blood flow that reflects the resistance to the blood flow caused by microvascular bed distal to the site of measurement. The cutoff is 0.7. And basically, if it is high, there is more possibility of a hyperthyroidism, basically Graves and all. The only thing is, whenever, even though power Doppler imaging we can use, still now it is not the standard of care to diagnose a Graves disease. Only you can assume there's a possibility of Graves disease. Definitely, you have to do a TSH receptor antibody or a technetium 99 thyroid scan to differentiate between the two. So whenever you're after learning what all tools to be used, definitely a patient comes to you how to proceed with the ultrasonography. First, patient should be positioned supine, head thrown back with a bolster, and you have to fix the frequency. Like you should use a high resolution properly, and you have to look at the thyroid first. First, look for the location. Is it in the normal location? Any other swelling in the ectopic location? Then take your dimensions, AP diameter, and you should always compare with the normal side also. Then you have to look at the nodules. Whenever you are looking at the nodules, as we all know, look at margin, shape, composition, echogenicity, echostructure. So you should definitely uh, scan longitudinally, transverse, and oblique ways. Basically, you may miss a nodule if you're only doing a transverse scan. So it's always better to see in all three ways. Then you measure the normal dimensions of right lobe, left lobe, isthmus as well. And this is the normal structure, like what you will see in a transverse ultrasonography. You can well very well make out the trachea, esophagus, right lobe, left lobe, internal jugular vein, carotid vessels as well. Strap muscles and cervicomuscles also can be very well visualized. Whenever you are looking at the internal jugular vein, carotid region, you can very well make out level 2, 3, 4, 5. That is very important in a thyroid malignancy lymph node assessment. Later, you have to look at the paratracheal area. Central area, which all areas I will specifically look at the over the pretracheal and right and left paratical, you have to have a ultrasound image to look at any enlarged central compartment node. Most probably, only thing is like in associated thyroiditis cases, you will falsely detect so many lymph nodes in that, but always look at the T2 in that term. So whenever you're assessing a nodule, look at the composition, echogenicity, margins, shape. So earlier we were always having ultrasound with so many features. So there was no lexicon available. So later the thyroid imaging, reporting and data system came up. So that was started by Horvath et al. He combined all these things, came up with something similar to Berat's to risk stratify the lesions. So these 5 characteristics at least you should look: solid composition, hypoechogenicity, microcalcifications, irregular margins, and taller than wider ratio. So if you combine all the 3, you can definitely have a assumption that you stratify the nodules. It is high risk, intermediate, low risk according to ATA or the newer ACTA classification, category 1, 2, 3, 4, 5. So whenever you are looking at it, you should definitely look at, is it a clear or almost completely cystic lesion? Spongiform, whenever the nodule is more than 50% spongiform, or we should call it as spongiform, it's a very low risk thing, and solid or almost solid, and cystic or mixed cystic. That is a very common terminology used in case of composition. There comes the echogenicity. Whenever you are commenting about echogenicity of a thyroid nodule, it has always been compared with the opposite normal thyroid lobe. So if there is echogenicity more than normal thyroid lobe, it's called hyper. Same you call iso. If it's less than that, it's called hypo. One more term to be added in that scenario is it's called highly hypo. That is whenever the echogenicity is larger than the, I mean, like staph muscles, then you can call it as highly hypoechoic. That is included in the ACR thyroid guidelines. So hypoechogenicity means decreased echogenicity compared to the thyroid lobe. ISO means similar one. This is the one I'm mentioning. Whenever you are finding an isoechoic nodule, better look it with your harmonic and color coding imaging, because you may be seeing a pseudolobulation in this scenario. In very hypoechoic, as I mentioned, if you compare with Mansi is hypoechoic, then that we will call it as very hypoechoic. Then the last one is called anechoic. It is having very less likely to be malignancy. It is a simple cyst without soft tissue component. And next thing about this one is called taller than wider ratio. This taller than wider ratio is having very high risk of malignancy. It is actually, I noticed in very few cases, whenever we find this, we can able to correlate with the high risk of malignancy. And regarding margins, there is smooth margins. That this is the one I was mentioning, ill-defined margins. This is the one very difficult to find out. The borders of the nodule is difficult to distinguish from the thyroid parenchyma. We have to call it as a ill-defined margin. In this scenario, definitely we have to combine it with the harmonic and the color coding margins. If it is irregular, this is the highest margin. It's called a speculated, jagged, or sharp angle without clear soft tissue protrusion into the parenchyma. This is having high risk of malignancy. So if we combine all these 5 things together, you can have your Thyroid's classification. So before Thyroid's classification, Elwood started it, but due to the very difficulty in using that one, later ATA came up with the ATA sonological pattern, and now it is ACR thyroid. So most of us is following ACR thyroid. So whenever you're working anywhere, whenever you're quoting any thyroids, always mention which thyroids you are doing. Is it quack, or is it RUS, or is it ACR thyroid? Because there are so many classification systems, there's no standardization in that. So whenever you are having this, always mention whichever classification you are following. And last few words about elastography. Elastography is basically the electronic palpation as such, because whenever we are using it, ultrasonography to risk stratify lesions in high risk nodule, 2-3 places we have difficulties like the macro calcification and in benign calcified nodules. One thing is that, other thing is like whenever you are having a hard solid cyst. So sorry. So elastography was started by Rago et al. In 2007. It is having 2 components. One is the strain elastography, another is the shear wave elastography. In strain elastography, you will be mechanically deforming the tissues using the probe. There will be a relative displacement of the tissue. for like harder tissue compared to the softer tissue. Their way you can make out between a softer and harder, stiffer tissue. And in shear wave elastography, it is not manual compression. The wave will be compressing that. The focused acoustic impulses will be causing this deformation, and you can distinguish between uh, stiffer areas. So there is a elastogram will be produced by this elastography. So if we are having more stiffer areas, then there's a possibility of malignancy is high. And if you calculate the index, that means if you compare, take a stiffness of between uh, harder area and the softer area, if it is high, that is also possibility of malignancy is higher. And this you should always know. Uh, the concept of strain elastography, instead of using transducer process, there's a shift of ultrasound A line. A higher density is transmitted to produce shear waves, which extend laterally from the insulated surface. Shear wave may be tracked to the lower intensity pulse to find the shear wave. It is basically using Young's modulus. So you should be knowing about Young's modulus, the elasticity versus force by area. So elasticity into strain is equal to stress. So it can be measured, in this elasticity can be measured in kilopascals. So if you combine, there's a paper from CRUZ, I think, that is combining elasticity plus terads. So if you combine both of these things, you can increase the sensitivity and specificity.